Some of you know me, some of you don't. So for those who don't know me, my name is Melissa. I am the Senior Manager for Specialty Academics for Aspen. Myself, along with my colleagues, Kristen and Ed, we get to travel the country and hang out with the OS and endo residents. And we get to just, get to know you guys and chat with you about opportunities with Aspen. And sometimes we get to do fun stuff like this, where we have special guests, Dr. Bruno from Straumann. Straumann is a premier partner with Aspen, for those of you that don't know that. And today, Dr. Bruno is going to be talking to us about demystifying immediacy and just discussing how the partnership between Aspen and Straumann, enable oral surgeons to be able to do immediate implant placement, and how Straumann is able to support Aspen in that aspect. First, I would like to introduce Dr. Desmond Brown, who is our VP of Oral Surgery. And then after Dr. Brown introduces himself, we will pass it on to Dr. Bruno. There is a Q&A button at the bottom, guys. So if you have any questions at any time, please don't hesitate. Just type your questions in and I will make sure that they get answered. So Dr. Brown, you want to go ahead and introduce yourself?
Hey guys, Des Brown, VP for OS support services with Aspen. I see some of the Aspen OS on the call, so most of you guys know my background. So I do a combination, and this is what Aspen allows. I am a faculty part-time at Indiana University, where I do basically full scope OS. I also am a surgeon at Clear Choice. That's the usual all on fours, zygoма, that kind of stuff. Definitely doing tons of immediate implants. And then I was full-time, again, like a typical Jamaican, multiple jobs. I was a full-time surgeon with Aspen. So I had 3 pretty busy jobs. What Dr. Bruno is going to talk about today is pretty much the basis of my practice. I can't tell last I have extracted a tooth and not placed any implant. So with this Straumann BLX system, I've had extensive experience. For those of you guys who have been able to go to the OCC and see the implants live in action, I invite the Aspen OS. Sent out an email a couple weeks ago, and for the residents who are joining, we have a partnership with Straumann, as Melissa mentioned, but we also have a live implant training where you get to place tons of Straumann implants. It's very, 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 very intense. It's a one-of-a-kind program in the United States where you actually are placing implants on live patients, doing guides and the whole 9 yards. But Dr. Bruno is the star of tonight, so I'll let him take over.
All right, well, thank you very much, Dr. Brown. Thank you, Aspen, for the partnership. It is always a pleasure to be here with you guys. I'm passionate about what I do, and I'm really passionate about implantology. And every time that we have this opportunity is a pleasure for us to be here. Thank you, everyone who is here. Good evening. I hope that this webinar brings value to your daily practice. And with that, let's go. So the talk of tonight is demystifying immediacy, and we're going to focus on the Straumann BLX system for that. Of course, you can do immediate implant or immediate loading with different types of implant systems. We're going to show you how we try to optimize the system that we have for this, and you're going to see why that is important, because it really does help you out when you're doing the procedures. All right, so I'm a prosthodontist. I'm also surgically trained, so I have degrees in implantology. I'm from Brazil, so in Brazil, implantology is a recognized specialty. So I have degrees in implantology, I have certificates in perio and oral surgery. And I've been with the Straumann Group since 2015 as a full-time employee. But before that, I was a big client of the Straumann Group. and I've used a lot of different systems and placing and restoring, and therefore I have a good amount of let's say experience on trying different things and understanding what works, what doesn't work. So let's try to help you guys out here on this webinar. All right, so the agenda for tonight is we don't have let's say 4 hours to be discussing here, right? So we have something between 45 to 1 hour, 45 minutes to 1 hour, and so we wanted to demystify the thing in a very simple way. And so for that, it's very important that you understand the fundamental concepts behind what we are thinking when we're making the decisions if we are going to immediately load or or place an implant immediately. And so we are going through those fundamental concepts. So implant stability, bone density, talking about the drilling protocols. And of course, then we're going to go through the implant system, show a little bit of the difference on the implant positioning from a regular implant positioning to an immediate implant position in extraction sockets, for example. And then we're going to talk about immediate loading. And of course, we have a bunch of cases to illustrate all of that. And of course, I would really like if you guys had questions so that we can discuss. So think about the questions as we go through, because in the end, we're going to open the floor for questions. Okay. So basically, immediacy in general, it is a function of these three things here that we are showing you in terms of the fundamental concepts. It is a function of implant stability, bone density, and drilling protocols. We are going to understand that the stability of the implant is very important for us to have success, especially if we are talking about immediate implants and immediate loading. You can have an implant with less stability in a healed site, and that implant might, also integrate very well. But if you have a component that will be pushing that implant, let's say, like if you're doing immediate loading, that will be a lot more critical, so that you have to have a lot more primary stability if you want to do some type of immediate loading. The other thing is, of course, if you're placing an implant in a healed site, you're going to see in this presentation, you have bone all around you. So it's much easier for you to stabilize your implant in a healed site than if you're placing an implant in an extraction socket that many times you don't have. If you're placing the implant in the right position for that crown, for example, it might be that you don't have enough bone around that implant, and so it becomes a little more challenging to acquire that stability, right? So why is stability important? So we know from already a long time ago that we have to have levels of stability, and in different papers, you're going to see different numbers. We know that we have papers showing up to 500 micrometers of micromotion being accepted. We understand that you can have, osseointegration with that level of movement. But you can see here levels of micromovement ranging between 50 and 150 micrometers are known to produce no detriment to osseointegration. And so if we want to be more on the safe side of things, if you want to be more like, I crossed all, I checked all boxes, then we would prefer to have torque values, and you can see here, consistent with these limits, recent recommendations indicated torque values at the time of placement should be greater than 32 Newton centimeters. And when we saw this from this paper some time ago, of course, when I say we, like all of us in dentistry, we started to try to place implants at 32 if we wanted to do immediate loading for multiples. So when Dr. Brown was saying that he was doing arches today, so when he does arches for clear choice, we always think about having 32 Newton centimeters as, let's say, my goal to place that implant there, to have stability on that implant there. We are going to understand that depending on the type of procedure that you do, this might be a higher or lesser type of requirement. It could be that you need, let's say, 35 for singles or more. It could be that for full arch, we used to do 32. We are seeing today that we actually can do less, but we don't have a number yet. So this is still the number that we have, in the science. And so But why is that? We are going to talk about it. The other thing that we learned from this paper here was that, as you can see here, in animal cortical bone, torque values of 100 Newton centimeters cause excessive bone compression that resulted in weaker osseointegration. And we can see this also in other papers, and even with micro fractures in the bone. And so, but they say, you know what, furthermore, torque values between 45 and 100 Newton centimeters have been shown to produce the same degree of micromotion. And so I think that that is key, right? It doesn't even matter if you're going to have a weaker osseointegration or not, at 100 Newtons or more. You are going to find papers saying that up to 150 Newtons, they didn't find any osteonecrosis or any problems. But it doesn't matter, because after 45 Newtons, you can see here that you have the same degree of micromotion as you would have at 100. That means that the bone cannot take torque like to the infinite, right? I mean, after 45, the level of movement that the implant has inside of the bone will be the same, because the bone will be a little more elastic, right? So it will not allow the implant to move up to a certain point, and then you're still going to have that little resilience that the bone has, and the implant will be able to move a little bit. And that is fine, because at that level, your micromotion will be really small and will produce even like less detriment to osseointegration, okay? But that is why we say that there is an stability range that we are looking for when we are doing all of these types of immediacy like procedures. And they're usually from 30, and we say 50 because we are giving kind of like a margin, right? I mean, of course, it's impossible for us to always hit 45. Of course, sometimes we go a little over. The implant is almost there. You don't want to reverse that out and drill again. So you have to, you keep going. Maybe you go over and you hit 50 or you hit 60, and that's fine. You should not have a problem with that. High levels of torque starts to become a problem when you are in very narrow cortical bone, where you are going to see today, where you end up not having a lot of nutrition that is located in a loose manner around the bone. They are within the haversian systems, and they can easily be crushed, and then you end up having some ischemia on that bone, and then you end up having the chance of having bone loss, right? And so that's why we want that stability range to be between 32 to 45. And of course, if you're doing singles, we are thinking about having that maybe between 35 to 45. And of course, we say 50 here again, just as a margin. And that's why on our torque ranges, you're going to see the range there, 35 to 50 as a range, okay? All right, but let's remember this a little bit. So when we do ortho movements, right, and we have that tooth being pushed, let's say, to the mesial, we are going to have compression in that mesial part of the socket, and we're going to have tension on the ligaments on the distal part of that socket, right? And what we have that allows that movement is we have osteoclastic activity. Remember that resorbing the bone, and we're going to have osteoblastic activity on the tension side, producing more bone. And this way we can move the tooth and move also the socket, right? Because we have osteoblast and osteoclast and all of the activity, okay? Why is that important for us to remember? Because the same thing happens in any type of, healing of the bone, right? The bone remodeling process occurs like that. We have osteoclast cells that will come through the bloodstream and will attach to the bone cells and will start to release acids and enzymes that will dissolve the bone, right? And then they will go away, and then the osteoblast cells will come and they will produce collagen, and that will adhere, the calcium will adhere to the collagen, will form new bone. And this is the bone remodeling process. And why is that important? It's because when you place that implant and you get a good primary stability, you get good stability of that implant, all of that bone that you are pushing around that is giving you that stability all of that bone will be lost, right? All of that bone that is being pushed will be resorbed, just like in ortho. When we push that tooth, we are resorbing that bone. But of course, you have also the secondary stability coming as soon as you are, as soon as you finish your surgery, replace your implant there, you have the healing process starting out, and you're going to have bone formation. And as you can see here, we have a high primary stability. Let's say if we did place the implant with high level of stability, we are going to have that primary stability level dropping, while at the same time we have secondary stability coming up. And of course, it will get to a point where it will bring the stability level to very good values where you can load that case, right? But we do experience this blue graph here, which is the stability dip, right? So we experience a dip in the stability. And that's why if you start already with a lower stability, that will not give you, let's say, a good, provision for your immediate loading, right? I mean, if you want to keep that stability high because you just loaded a crown and now, that implant cannot become loose, right? Because if it does, you're gonna have a failure. And so because of that, you want to keep that stability level high. And that's why, for example, in the Straumann S-selective surface, we have a hydrophilic surface that will allow us to push that secondary stability curve to the left. So it's a surface that is mostly free of carbons and hydrocarbons. And because of that, the body does not have to remove those from the surface, and osseointegration can start faster. And so we have a lot more stability faster, and that's why we can many times load much sooner than a lot of the competitors who don't have this type of surface technology. And as you can see, the aim was always to have either a very little, like a lot smaller stability dip, or maybe not have a dip at all, right? So that is the objective of the technology, so that when you're doing immediacy procedures, you're not thinking, well, it was good in surgery today, but what if next week, right, I lose all that stability? What if my patient now is not compliant? What if patient bites on something? What if I lose my implant? And we're trying to hold that level of stability high since the beginning. All right, but let's go back to bone density, right? We have, like I said, immediacy procedures should be a function of bone density with your drilling protocols, right? We talked about this with the stability levels of your implant. So we have to understand the bone density to understand what is it that I can do in terms of my drilling protocol to allow my implant to have enough stability for me to be able to deliver some type of immediate procedure. So this here came from Lekholm and Zarb. I don't know why the citation is not here, but this is from Lekholm and Zarb. And they came up with this description of bones type 1, 2, 3, and 4, which gave us some understanding. And of course, if you are in implant dentistry, you know that everybody knows this classification. And we understand that when we have harder bone, it is easier for us to have stability. But when you have softer bone, it's much more difficult for you to have stability, right? That bone doesn't give us enough mechanical resistance, to resist the compression of that implant. And therefore, we end up with torque levels that are much lower on soft bone than what we have in hard bone. And of course, these are the these are the customary places for you to find these types of bones. Of course, this varies, of course, from patient to patient. I've had patients with anterior maxilla with type 1 bone, but of course, that is not the usual. The usual is what you're seeing on the screen, right? Type 1 and 2 being the anterior mandible area, type 2 and 3 being posterior or the anterior maxilla, and then type 3 and 4 being the posterior maxilla. But like I said, this varies. Of course, this classification of Lekholm and Zarb is very like didactic, is more for you to understand and to tell other, other clinician about the case and all, but it doesn't really comprehend all of the clinical or the different clinical aspects that you deal with. And so Eckrich et al. In 2018, they came up with this new classification, giving like subclassifications to the Lekholm and Zarb, and they came up with the type 1 was already there, so the type 2A, type 2B, type 2C. This is actually very interesting because we do find a lot more, in real life, the bones are more like this than like Lekholm and Zarb had classified. Because, for example, you can have a very dense cortical plate and you can have a very bad medular part of the bone, and that would be a type 2C bone, right? And this is important for you to know because when you are creating your drill protocols, you have to take those things in consideration, right? So, for example, usually when I am placing an implant in type 1 bone, I am going to drill with the standard protocol. I'm going to use all the drills all the way to my implant size, and I'm going to place my implant after, right? Because that type 1 bone already gives me a lot of torque when I am placing my implant, and I don't want to have excessive amount of torques. And so because of that, I have to drill more. I have to drill up to maybe the implant size to be able to place my implant in. However, if I am dealing with a type 4 bone, then I know that's very soft, mushy bone. Then I have to maybe not drill all the way with my drills. I have to under prep, right? I have to prep less in order to place my implant in a tighter space. And so my implant can produce a lot more compression on that bone, and that will give me back a higher torque level, a higher stability, right? But in the 2C case here, for example, it is both, right? It is very hard on the outside and it's very soft on the inside. So what do? Right? So we do have to consider those two different entities as separate entities, and I should take care of the cortical plate as I would for a hard bone, and I should take care of the medular area as I would for soft bone. So maybe I'm going to drill with my pilot drill all the way to length, and then maybe on my next drills, I'm just going to prep the cortical, but not the medular anymore. And then I'm going to place my implant, right? So this classification, I think is more clinical than the first classification. Okay? And let's understand a little bit more about the two distinct bone surfaces, right? We just talked about you have cortical and you have medular. Why is that important? Of course, you guys have seen this in dental school, and this is, it's boring, I want to sleep. This is very important because we should understand what they have inside in terms of just the histological contents, because this will make a big difference when you're placing your implant and when you are working your drill protocol, and you will understand why. So of course, we have a cortical plate, we have medular bone, and these are histological cuts from Junqueira and Carneiro textbook. And you can see here, cortical, very dense tissue, right? And you can see cancellous much looser, right? These are the important things that I want you guys to learn today. When we remove this piece here from the mandible, you can see this piece here increased in size, zoomed in, and this is what the cortical plate would look like, and this is what the medular would look like. And the medular here, you can see that the vases would go in and out of the trabecula in a very loose manner. And so what this means is when I place my implant and when I compress that medular zone, all of my vases that are, let's say, going around my implant, I can move those vases to the side. I can keep compressing my bone, and my vases have some space to be pushed around. right? But here, if we zoom in on this cortical zone, and you can see these channels here, if we zoom in, this is what you see here on the right, and those are the Haversian canals, right? And of course, you have added canals called Volkmann's canals. So those are the Haversian systems, those cylinders that you can see here. And the vases on the cortical part of the bone, they are located inside those Haversian systems, and this is cortical bone. That means that if I'm placing an implant in cortical bone, and if I'm compressing that bone, then because this is all dense, there's no space for my vases to, be pushed around. What happens is that I would just crush my vase. I would just either obliterate or completely crush that vase. And what that does is, if you have just a little bit of bone, if you have thin cortical bone on that area, and if you crush the only nutrition that that bone has, that means that that bone will not stay alive. That means that you will lose that bone. And that's when a lot of clinicians will experience that bone dieback on top of your implant because of this type of pressure. That is not the only reason that you have bone dieback. There's reasons also because of the type of connection that the implant has, but that is in another lecture. But when you're placing, you can also, even if you have a good connection, even if you have a more stapler-based connection like you will have with this system, you can still have bone dieback if you are over compressing the cortical plate. And this is very important for us to understand, and I wanted you to understand why. Okay. All right, so on the drill protocols, so drilling protocols, we have the standard protocol. So usually that one is provided by the manufacturer. That if we go back to Brandmark's time, when he first published his studies on osseointegration, what Brandmark brought in terms of a standard protocol for that specific cylindrical implant machined surface that he had, external hex that he had, was you would take out the core size of the implant out of the bone. And so if I have a 3.75 implant diameter, my core was 3.05, and then my threads were 0.7, I would remove 3.0 out of the bone because I was, giving exactly the space for that core, and then the threads would go in. That was the standard protocol. And so usually the implant manufacturers would provide us with a standard protocol, okay? However, the standard protocol, like I said, yeah, it might be great for maybe hard bone. Maybe hard bone, you still have to prep a little more these days. But it would not be great for those cases where we have soft bone. And so in those cases, we actually prefer to do what we call the under preparation or the under instrumentation or sub instrumentation, right? Where we are going to remove less bone than the standard protocol, okay? And that could be a lot of different things, right? It could be that I'm just gonna do one drill less, or I'm just gonna drill with 2 drills less. So the level of under prepping, I will choose, and we'll talk more about this, but I have to choose according to what bone density I think that is, right? Because if it's a 4, let's say I'm going to under prep even more. If it's a 3, maybe I'm just going to under prep a little bit, right? So there's this differences. Over preparation removes more bone than the standard protocol. So that's when we have to remove more bone than the core size of the implant, not more than the diameter of the implant, because if you do that, then you have 0 stability, right? But if you remove more than the core size of the implant up to the thread size, okay? So those are the different drill protocols. And of course, we use all of this. Like I told you before, I can use an over prep for the cortical part of my bone, and I can use an under prep for the medullary part of my bone, and this could be at the same site. So that means that I am customizing my drilling protocol according to my bone density. And this is key in immediacy procedures. So here, for example, we show you that on our kits, on the BLX kits, you're gonna find this recommendation. So instead of us recommending just the standard protocol, we actually printed in the kits recommended protocols for different bone types. So if you have soft, medium, or hard bone, depending on the implant diameter that you're placing, we are telling you which should be your last drill. So let's say if you have medium bone, and if you are placing a 4.0 implant, then your last drill should be the red one, should be the 3.5. And optionally, if you want to remove more on just on the cortical, we can use the 3.7 just for the cortical plate. And then you place your implant. Okay, so we are offering you more recommended protocols. But of course, depending on your level of experience, if you are a very experienced doctor, then you are going to find your own protocols. Maybe you're going to see, oh yeah, this makes sense, but I actually prefer to maybe drill a little less in this case or a little more in that case. And this is up to you and how you feel the bone. And this is important. We have this paper that was published in 2010 and saying how important it is. It was by Greenston et al., including John Cavallaro, Benjamin Greenston, Gary Greenston, and Dennis Starno. And what they were saying in that paper is that the 2mm twist drill, which was the pilot drill for that system that they were using, can be used as an integral facet of the fine-tuning treatment planning. So what they want to say is that when they use the first drill, the pilot drill, they're trying to feel the density of the bone and to confirm what they had, what they saw on the CBCT, and then adjust their drilling protocol, okay? So of course, in our system, instead of having the 2mm drill, we have the 2.2 drill, okay? And so when we are using the 2.2 drill, we are going to feel the bone and to understand what is it that I need to do now to be able to customize my drilling protocol based on everything that we have been talking about. Okay, so if it's hard bone, maybe I should drill more. If it's a soft bone, maybe I should drill less, right? So I'm going to try to understand that. Okay, and of course, this goes back to what we talked about here, right? If I am in hard bone, I know that I'm going to drill more, and in soft bone, I know that I'm going to drill less, and this could be part of the same site, right? It doesn't have to be, let's say, posterior maxilla has 3 or 4 type bone, right? Or this could be, for example, a lower first molar. It could be that it has a very tough cortical, maybe 3mm of cortical plate that is really hard, and it could be that after it has a black hole, and then we have to be able to customize appropriately. So this is from our, let's say, from our manual, right? So it's telling us that we should initiate the osteotomy with the 2.2 drill and define the drill protocol after that, right? And then, of course, we are saying that such that the final insertion torque does not exceed 50, because we know that you have no gains after 45. And so 50, we're already giving you, 5 newtons extra. Okay, and we want the implant position in the end to be 0.5 or a millimeter subcrestal. I prefer a millimeter subcrestal. Okay. All right. What about the implant system? So the implant system plays a big part in all of this, because we are trying to place an implant in a bone, and we're trying to get a higher primary stability, right, for these immediate procedures. And if I have an implant that is very smooth, that is not very aggressive, that means that I will compress the bone less. And we don't want that, right? So let's talk a little bit about the advantages of the BLX system. And of course, we'll start with the alloy. We have an alloy that is a very tough alloy. It's the most resistant / most biocompatible alloy that we know of in the market. This is a rock solid alloy. It's a mix of 85% titanium and 15% zirconium in average. Okay, and this will, you're gonna see here, for example, that on a 3.3 implant, it has higher fatigue strength than our competitors on the 3.5 diameter. So it's very, very strong. It's stronger than titanium grade 4 and titanium grade 4 cold worked. So it's a very strong alloy and very biocompatible. And it's very important for us to have something like this if you want to have an implant that will be safe, right? But of course, on the outside design, this of the implant, that is what the macro design, this is what's going to make a big deal for us for immediate procedures, because we want to compress the bone. We want to have a good stability there, right? And so, of course, what you saw here in this video animation was the chip fluid. So as the implant cuts in, it will collect all of those bone debris, and that will redistribute the native bone. And so all of those, they become induction centers, right? So for your osseointegration, that's very important. But on our story here, on our subject, we need, for example, we have here 2 cutting blades. And so the blades will be very important to cut through cortical plates, right? In this bone example that you're seeing, we have a cortical plate on the top, but if you're placing this in sockets, you're gonna have to have the implant going through cortical plates in a bunch of different ways and places. And so we have 2 cutting blades to allow the implant to cut through those cortical plates and to be able to immediately engage and to anchor in the surface. And because of these long threads that you can see in the apical part of it, we are able to stabilize this implant in only 3 millimeters of bone, which is awesome, right? Sometimes you are in a big socket. There's not a lot of bone for you to stabilize that implant. You need a little bit of that bone that you have maybe beyond the socket if you have the space, or maybe just in the septum that you have in the socket. And so this is important for us to be able to stabilize that implant better, okay? But of course, this is very, very important for stability. As the threads go up, they become progressively more compressive, right? So as they go to the medullary bone here, you can see that we are compressing the medullary bone more and more as the implant goes in, okay? So this is very important. We start with cutting threads, with the cutting points here. As you can see, each thread, as it gets cut by the flute here, each extreme here of the threads, they have a kind of like an X-like of cutting, but then the threads become progressively more compressive, and they can create more resistance from the bone, and therefore we can have a higher torque, a higher primary stability, okay? We have a gradual horizontal bone condensation, okay? All right, but the other thing that is important, remember, we don't want to overcompress that cortical plate, right? We want to compress the medular, but not the cortical. Because of that, we have a reduced neck diameter. And so the neck is reduced compared to the drills. And so when we place the implant, we already have a little bit of space here, allowing us to have some relief in the pressure at this zone, okay? And of course, when you're choosing the implants, we have 2 different types of bases, but the regular base and the wide base, I'm going to show you both. It's a very easy implant system to use because we have one connection for everything. So you don't have different platforms like wide platform, narrow platform, regular platform. So this is all the same platform. But depending if you are dealing with hard bone or with a soft bone, you can choose, you know what, I'm going to use a 3.75 implant in a hard bone, and I'm going to use the 4.5 in a soft bone because the threads are longer and it's going to compress my medular part more. So you can see here from the 3.5 all the way to the 4.5, the core stays the same, the threads get longer to allow us to compress the medular part more. This is the wide base. You can see that the same thing happens. So from the 5 to the 6.5, the size and the core is all the same, but you can see that to the 6.5, the threads become longer. So if you want to compress the medular more, you have this opportunity, okay? And so this is the core size of the regular base and the core size of the wide base, okay? But in the end, the connections are all the same. It doesn't matter if you have a regular base or a wide base, you can use the same component in all of the implants. Like I said, there's no wide, narrow, or regular neck, okay? That takes me to that connection. So you can see inside, if it's narrow or if it's regular or wide base, you can see the connection is the same for all implants from the 3.5 to the 6.5, okay? And that means that you guys have only one implant driver, one scan body to use, or one prosthetic system, right? One temp abutment, one, final abutment. So you don't have to have different types of platforms. The connection was also designed, it is a more taper-based connection, so very tight conical sealing so that you don't lose bone on the top of your implant, and you also are able to have your crowns not getting loose because it is a friction fit, more taper based connection. And of course, we have the internal indexation designed to withstand the torque, because if you are putting a lot of torque in this implant, we don't want the implant to deform inside, or we don't want the driver to break or the implant to break. And that's why the implant is made with a very, very strong alloy, like we talked about in the beginning. And that's why this index is made in the torque fit design, which allows us to have up to 245 newtons of torque without deformation, okay? So it's very important for the procedures that we are talking about. And of course, we don't want to damage that more taper, and there's why we only, when we're torquing the implant, we only torque through that index. And when we're trying temps and different types of components, we are only using this outer rim here. We leave, you see, like all of these parts, they only touch the outer rim. We leave the conical area in friction only for the final abutment, okay? And as you can see, we can have up to 460 newtons here without any type of deformation and without having it allowing to leak, right? All right, so implant positioning. So when we are doing immediate implants, it is a little different than when we are doing implants in healed sites, right? So here on the left, we have a BLX in a healed site, and you can see that little gap between the narrow neck part of the implant and the bone, right? So we're relieving the pressure on the bone so that you don't have bone dying back. But I have bone all over, all around. So that's easier for us to get stability. But when you place an implant in an extraction socket, look at the amount of space, right? The big gap that I have here. It's a very different thing. And so we have to be mindful of the positioning, how important it is for us to engage into some type of native bone, either on the more palatal area of that socket or in the septum. We have to find a way to anchor that implant, even if it's a little bit, like we showed here, 3 millimeters, you can have a good stability with BLX, but you need to be able to engage some type of good bone inside of that socket. And of course, you also have to choose an implant diameter that is appropriate to your immediate extraction site, right? So let's take a look at this. The size of the socket and the size of the gap, right? If you guys are doing already some type of socket preservation, which we call alveolar ridge preservation, right? ARP. If you are doing that, you know already that every time that you extract a tooth, because you are extracting the tooth, that bundle bone doesn't have any nutrition anymore because you extract all the nutrition of the bundle bone, and therefore you have the collapse of that buccal wall of that socket, right? And because of that, we are going to have more bone loss. We end up with a ridge that is usually more collapsed, let's say, than what it was before. This only doesn't happen much when you have buccal walls that are thicker than 1 millimeter, right? But when we have buccal walls that are thinner than 1 millimeter, which is 90% of the cases for the anterior zone, then we know you're going to have a big collapse. And so usually you do alveolar ridge preservation. So when you place an implant, you have to consider that. You have to be mindful of that, because let me show you here. You place an implant, and then you have that gap. And then even when you do some type of socket preservation, you are going to lose some bone here. Why? Because that bundle bone will be lost regardless, right? What we have is a compensatory mechanism that when we are going to lose that bone, but whatever you grafted that site with, like the allograft that you put there, will create another wall. And so when you lose that, first bundle bone, you find a wall if you had grafted that site, right? But if you did not, you're going to keep collapsing, right? So here you can see, even with grafted, bone was lost. And according to these different papers that you can see here on the left, they found different levels of bone loss, of horizontal loss, even though they had grafted, okay? So according to Khan, we had 1.5 average horizontal loss in that ridge. And so because of that, now we are going to place an implant. We are going to select our implant by the buccolingual aspect of our socket, and not by the the mesial distal space that we have. Because you could, because you have, let's say, 9 millimeters here, you could think, oh, I can place a 5, right? If it's a molar or something, you could say that because of your area, of your prosthetic area. But it's actually not. When we're placing an implant inside of a socket, we actually need to leave 3 millimeters of space between our implant buccal wall to the internal, or sorry, to the external wall, to the buccal face of our buccal wall. Okay, so we need to have 3 millimeters of space, because we are expecting that socket to resorb 1.5 millimeters, and then we will still have 1.5 millimeters of bony wall to your implant. Okay, so that's very important for us to understand when you're placing implants inside of sockets. So here we can see not only we are placing the implant further away from the wall, but we are also using this palatal area here of the bone to engage the implant in, and therefore have more stability, right? So you're placing the implant, you're temporizing your case, and you are filling the gap with biomaterial like you would do for a regular socket preservation procedure. All right, but we talked a lot, and we showed you some, and we talked about the didactic and the reasoning of all of this, but we didn't show you cases, right? So let's show cases and talk about them. So we are going to start with immediate implant. So here we are doing an immediate implant case, but we are not doing immediate load, right? And we have a lot of clinicians that would do immediate implants a lot, but not a lot of immediate loading, especially if it's for singles, and that's fine. So we can see here that this canine had this fistula here. I traced the fistula, I took to the canine. We removed the canine very atraumatically. As you can see, we did not open any flap. You can see that the tooth is wholesome here, right? So nothing is left there. And you can see that, yes, the fistula came from that socket. I measured the defect, and yes, it was only, it had a bony defect, but not a tissue defect here, right? So I knew I could debride, clean everything up. I could place my implant. So I went with my drilling protocol. I placed my implant in position, and as you can see, I'm reaching 35 level, close to 35 level here of torque. But in this case, I was reaching 35, and then it went back down to maybe 20, and then it would go to 35 and then back down. And then I was kind of like hesitant. And I was like, you know what? I'm not going to load this case. It's a canine. I'm like, it's better for me not to do it. And so I just placed a healing abutment, as you can see, not a cover screw, because I wanted to already preserve all of this space, not allow the bone to grow over and then give me work to have to open everything up again. So I already put a healing, kind of like the diameter that I thought I would need. And so then you're gonna see here on the next slide, I did my socket preservation with the LEN technique, the ice cream cone technique of the membrane. So put the membrane inside of the socket, put the bone grafting between my membrane and my implant, and then I covered with my membrane, collagen membrane, and then I sutured the membrane to the marginal gingival tissue of the palatal side. And because the patient would not get out with without a tooth, of course, I gave the patient a temp, and the temp was actually luted on the neighboring teeth. And as you can see, there are PFMs that the patient already had. And so I had to lute with composite on PFMs, not a great adhesion there, right? So although I did use fluorhydric acid, but it's not great anyway. So anyway, what we wanted to keep the emergent profile here for the future crown. And so because of that, when I got the temp from a denture tooth, and then I had to work the base of that temp so that my base would be exactly the emergence profile. But as you can see, I'm not putting pressure on it. It is just holding my critical contour here, just holding my gum tissues without any ischemia. I'm not pushing down on this membrane, right? And then so I luted them together, and that's how I left the patient. And so this was 6 months follow-up. And as you can see, emergence profile continued the same. As you can see, big implant inside and integrated. And actually, a friend of mine finished the case for me there. And the patient had already PFMs, didn't want to change the PFMs, so he just wanted another PFM. And so that's what my friend did. So my friend, Dr. Ricardo Pereira, did this case there, the prosthetic part of it. And so he just linked the temp abutment to that temp that I had there, preserving that emergence profile. And then he transferred that to an impression coping. And then when he took the impression, he had exactly the replica of the base of that temp there, right? And this is what the lab created. And this is what he delivered to that patient, right? All right, immediate load. Okay, so in this case here, we had two side-by-side implants, but they were in healed sites. The one in the molar was actually an early socket preservation site. So we had 1 month of socket preservation that came from a friend of mine. He referred the patient. Well, he did the case, and I got to do the implant after, and I could only do it in that time, so I went for a very early approach. As you can see here, infiltrations, local infiltrations. You can see the incision with an angle scalpel handle. Open it up, put my stent, and you can see that I had bone going all the way to almost the zenith of my future gingival margin. I don't like that. I want to have 3 millimeters of space between the zenith of my future gingival margin and the bone. And so therefore I had to start working with some parabolic osteotomy to recreate the space of biological width. If I don't do this, my premolar here would be 2/3 of the size of my canine, right? And so we started to drill, and I was gauging the density, putting my pins. And then I went up to the last screw, and I went to place my implants. And then when I was placing my implant, I actually saw that, my parabolic osteotomy was not enough. I have to place this deeper. So I placed the implant deeper, and I used a bone profile drill to remove more bone around here at the top. And then I also placed the molar in that early socket preservation site. And you can see that the levels that I got were very good levels of torque. And so I was able to immediately load the case. So I placed the healing abutments, sutured them up just to be able to suture this loosely, because then I removed them and I put a temp coping in each one of them. I cut the copings up to the position that I wanted. And then I started to pick up my temps. And I know we don't have time for this, but we do have a presentation just on how to create those temps. for those. But as you can see, we were able to backfill them and finish them up. And because they were side by side and I was doing immediate load, I decided to leave them together for the osseointegration time. And then after that, we separated them into different, single units. Immediate implant with immediate load. So this is when you put both things together, right? So in this case, we wanted to have, we wanted to extract a molar, place the implant, and give the patient a temp, and the patient got out with a temp already. We wanted to make sure that we gave them a great provisional for that case. And as you can see here, this is a paper that talks about how to produce a good base of your temp, right? And so talking about subcritical contour, the critical contour, and again, we can talk about this in another lecture on provisionals. But here is the case. So a molar being segmented, we went with the optional spear drill. We went through that segmentation just to make sure this was free-handed. So we wanted to make sure that we had it right in the septum. And then we removed atraumatically each one of the roots separately. We went with the 2.2 pilot to feel the bone. We went for our protocol, the drill protocol that we thought was convenient for the bone density that we had. Then we placed the BLX at 5.5 by 10. And as you can see here, great level again of torque that we have of stability. So with that in position, we usually have the positioning of the implant. You're gonna know when you join Aspen, you're gonna see this 3 millimeters from the zenith of the gingival margin in, right? And 3 millimeters, as you learned today, from the buccal in. So 3 by 3, you're gonna learn this with Dr. Rawal there as well. And so implant is in, you can see guide pin here, a bone profiler to remove any type of bone that could be interfering with my temp. And again, picking up a temp, backfilling the temp, finishing the temp up, polishing the temp up, grafting my site. So while I'm grafting, I put a narrow healing abutment just to allow, so that I don't have any graft going inside of my implant. I graft around the socket so you can see all of the graft, and then I can place my temp. And as you can see, it is occupying all of that emergence profile area, right? So in this case, we didn't even have to suture. Okay. And the last case that I want to show you guys for tonight would be the immediate implants plus immediate load for fixed full arch rehabilitation. And maybe I should have shown you this in the beginning because it's actually much more difficult or much more risky, let's say, to do this right in a molar in a single unit than to do a fixed full arch. But so this is what we use for this case. This is the patient when she came up. This was the CBCT. And of course, in a regular approach, if you're just placing implants straight, there is not enough bone for this case. And so, of course, we went for an all-on-X type of situation with tilted implants. And so we gave the patient the infiltrations, and we went for the procedure. Incision, opening the flap, removing all of the teeth, or the remaining parts of the teeth. She had a bridge here. She had, teeth that were very deteriorated. So we reduced the bone. You can see here going for the bone reduction. And then transilluminated to find the anterior wall of the sinus. And then here we are showing you how to use the Straumann Pro Arch guide. So we use the 2.2 in the center of the ridge to place that Pro Arch guide. The Pro Arch guide will give you an idea of the angulations as a backdrop. And so we usually do angulations up to 30 degrees when we're doing hybrids, and we're doing 45 degrees when you're doing hybrids, and 30 degrees when you go for zirconia. Of course, this is changing. Zirconia is becoming better and better, and we are seeing now some also doing 45s for zirconia, but we are still waiting to see what science says about this because we don't have long-term, studies on it. So usually, if you want to be safe, 45, you can go up to 45 degrees for hybrids and up to 30 for zirconia. And so placing this in position, and I wanted to go for an all on X. In this case, I wanted to do 4 implants. My friend who I was doing the case for, who was going to do the pros, the same guy that did my that other case, Dr. Ricardo Pereira. So he wanted 5 implants, and so I gave him 5. But I was going for the V4 technique, so we angle all of the implants. So the intermediaries here, I'm angling a little less to 17s, and then I'm angling my distal ones to 30. Oh, sorry, the intermediaries to 30 and my distal ones to 45. And then I was looking for this situation here in the bottom. But I actually gave him another implant, the 5th implant here in the midline, because he really wanted that. And so we did that. So drilling protocol, according to the bone type, and probing and placing my implants. So we were able to place 2 16s in the distal areas and then 3 12s. You saw that that would be impossible if we place straight implants. And as you can see, we were going for the range, so 35 to 50. For fixed full arch, we actually can torque even less than 30. We have more and more papers showing that now. 30 would be, let's say, the less number that we have from the science, but we are now seeing more and more evidence that you can actually load with lower torque for fixed full arch. But I was trying to get at least to that level, and so we got that, although it was soft bone case. And then implants in position, multi-unit abutments in, we call them SRAs. And so SRAs in position, and you can see that one implant or maybe a couple implants had a little bit of the thread showing they were inside of sockets that had defects. And so for those, so you can see this one here. So for that one, we actually did a little bit of grafting. We put the protection cylinders on top, as you can see, and then we started grafting that area, and we cover it with collagen membranes, and then we sutured everything up, and then we were able to go for the conversion. So you can see the temp copings, and we are converting an immediate denture as a fix, right? And then we were able to work on that, finish that up with polishing protectors here, and give that to the patient on the same session. And of course, adjust the occlusion. As you can see in position, adjusting the occlusions, and torquing the final prosthetic screws to 15 newtons, and then putting some Teflon tape and some Fermit, so temp composite on top of that Teflon tape. And then we do a little bit of Vaseline to make everything very smooth, and then we light cure it. So this way, when the patient comes back, this is very easy for me to put a probe and remove. And usually when I remove that, it comes together with the Teflon tape. Okay, so it's very, very practical when you have the patient still in the temp phase. And this is how the patient got there. This is how the patient left. And this is where the implants placed. All right, guys, I know I'm a little bit over my time here, so I think this is a great time for us to finish and open the floor for questions.
Any questions, guys? I'm sitting here listening and I'm thinking to myself, I didn't go to dental school, but I'm ready to place an implant. Let's go.
Awesome.
Actually, Dr. Bruno, I have a couple of questions, because obviously, there are different school of thoughts to do, fixed cases, depends on the literature. A couple of questions. So when do you, I know that a lot of times people ask me this question and I have my own philosophy, but when you decide if you're going to use a healing abutment versus a cover screw, what is your minimum torque that you choose?
Yeah, like you said, there are different like papers. There's nothing like really definitive on that. What I usually teach on the courses that we have is that you should reach at least 20 newtons of torque to place a healing abutment. But on that, and I know that some people say, oh, 25, some people say, no, just 15 is fine. If you use a healing abutment as a cover screw, then it could be a very low torque because it will be like a cover screw, right? Like I did in that case where I did the canine. So that's one important thing. But the other important thing about it is the healing abutment should be selected appropriately as well, because what we see a lot happening is that a lot of people don't know how to select healing abutments. And so the diameter of the healing abutment should be matching the emergence profile of the tooth you're trying to replace, but the height of the healing abutment should be flushed with the gum level or slightly above it. What we see a lot is healing abutments that are going all the way up, like above the gum level. And what that does is it gives the patient a little bit of a post there for them to be, putting their tongue and knocking that off. And also when the patient is eating, they can hit that with the food a lot more often than if that was at the gum level, right? So in that case, then the stability for that implant should be even higher, right? If you have a healing abutment that was selected wrong and is all the way up there. So those are the things that we have to be mindful of.
So we have some other questions coming in here. I will just go in the order that they're coming in. So Dr. Novak would like to know, what is your opinion of VersaBurs?
So VersaBurs, they're very interesting. They are very good for specific procedures. Just in terms of osteocondensating, I think that depending on, and I mean, I never use them a lot because they were launched not a long time ago. And I've used to try some things with it. I think that if you have an implant system that really compresses the bone, if you under prep drastically, you're gonna get very similar results that you get with VersaBurs. What I think VersaBurs are great for, are awesome for, let's say sinus bumps, or some types of when you're doing some ridge splits and you use them, I think they're able to push the bone a little more and like open that ridge a little more. So I think that they have their good applications that you can use the VersaBurs, and of course you can also use them for condensation. But I do think that the under prepping that you do and the implant system that you use are also very important, because if you think about it, to use VersaBurs, you have to use the first pilot on the to extract bone, right? You don't start just like condensating. You extract the first one, you remove, and then the rest you condense. That would be the same thing as just under prepping drastically, just doing a pilot and then placing an implant, and then the implant itself would condensate the walls, right? The push the medular bone out. What I don't like about VersaBurs is that if you are not experienced, you can, let's say, overheat the bone by condensating too much, overheat the bone, and then you might have implant failures. And so that is but assuming that you know what you're doing, like you're experienced, you should be fine with it. I have a lot of colleagues that love using VersaBurs for different purposes, but to me they are, I think of them more for sinus bumps and for ridge splits, for things like that.
Okay, next question. When doing overdentures, do you ever bury the implants deep enough to have a healing abutment instead of a cover screw to make stage 2 easier?
Yes. Overdentures, there's even enough evidence now in the literature, you can immediately load overdentures. I know that maybe I was too bold in saying this here, but we have evidence in the literature to say that. But if you want to play safe, do cover screws. You can do healing abutments. You can do short healing abutments. Like I did, like S cover screws, or like have just a little bit going outside of the bone. But you can, if you do healing abutments, and if you want to play safe, if you don't want to, let's say, be bold enough to do that, to do any type of immediate procedures on them, then you would have to do some type of soft relining, or some type of mechanical relief at the area, or both, if you don't want to have any of the pros touching that, right? Because sometimes riskier than having an immediate load would be having something bumping on that healing abutment, right, that you have on your overdenture. And if you are doing overdenture with a healing, make sure that you do what we talked about before, having the healing abutment flush with the gum and not sticking out of the gum, because that will give you even more vulnerability to have something knocking on your implant, before it should, right?
We actually have quite a few questions. I noticed on your immediate implant on the canine, the implant was buried quite deep to the palatal bone. Does that cause any restorative issues?
It's actually the opposite. That causes restorative paradise. I have restorative issues when I have implants that are placed shallow. And let me tell you this is the biggest mistake that I see clinicians doing all the time, is placing implants too shallow. Now, let me give some more information on that. You should not place implants subcrestally if they don't have a more taper-based connection, a deep conical connection. Because if they don't, you're going to have a lot of bone loss. So you can only do this in connections that you know they are more taper-based, that they're sealed, that you know you're not going to have this type of problem. You're not going to have saucerization. The BLX system is one of those that you don't have this type of problem. You can actually place the BLX deeper than what we said, the 1 millimeter, because you know you're not going to have that problem. So by placing it deeper, and you saw deeper because it was also on a socket, right? Remember, we need to have at least 3 millimeters of space between the zenith of your future gingival margin and the bone. And if you're placing the implant at the bone level, your implant would be also 3 millimeters from that future gingival margin. But if you can place the BLX a millimeter subcrestal, that means that your BLX could be placed 4 millimeters away from your future gingival margin, right? And that's if you're not placing it even more subcrestal, which you could, because it's a safe connection. If you don't need to, you don't have to, but you would have at least 4 millimeters of space between that implant and the future zenith of your gingival margin. And you saw in the end how the case ended up, right? So the emergence was exactly where it should be. The parabolic, like scalpel anatomy was exactly how it should be, because not only we placed the implant in a great place for the restorative, but we preserved the emergence from the start, right? From the day of surgery.
Any further recommendations concerning distances when placing implants would you have if placing immediate implants, if flaps/drilling bone was required for the extraction, as in more traumatic extractions?
Wait, I don't know if I got the last part. Can you repeat that, please?
Sure. The last part was, I guess they're referring to more traumatic extractions.
Yeah, so even if you have more traumatic extractions, you have to understand that you need to reconstruct the ridge, right? So let's say if you're not experienced, and if you want to, let's say, extract it, and you just want to reconstruct the ridge, do this on a staged approach where you reconstruct the ridge first. Let's say it's kind of a socket preservation, right? But you will do like a horizontal ridge preservation. You lost, let's say, that buccal plate. You fill all the socket with the biomaterial. You will fill in until that wall, you regain the wall, so the wall is even with the neighboring sides, right? So everything is looking good. You put a membrane, and then you wait, and then you place your implant. You can do that. But if not, you can place an implant at that same day, because the immediate implant success is more about its if you are able to place that implant with enough stability for that implant to also integrate, right? So you can still also integrate, place that implant in, do the whole construction that reconstruction that you would do even if the implant was not there, place the membrane, and then wait for osseointegration and for the healing of that area, and then you can continue with the restorative procedures. I actually have a case like that documented. We didn't bring here because it was I thought it would be a little too much, but it's the same thing. It's a very simple approach. Again, it's just the two things are not related. If that would not be a motive for me to not place my implant. If I have a big defect on a socket where I don't have any place to stabilize my implant, then I would not place my implant. I would first reconstruct that ridge and then place my implant. But if I have a way to stabilize my implant very well, even if I don't have a buccal wall or something, I would place my implant and then reconstruct the buccal wall with biomaterial. The only difference from this case to that canine is that canine I did with that ice cream cone technique from Elian, and that one is because the way that he created that technique, you can do that with a closed flap. Now, if I had a full, blown out buccal plate, then I would have to open the flap instead of doing it flapless, right? So I would have to place the implant, reconstruct everything with the flap open, put the membrane, and then close everything up.
What is your preferred way to under prep?
What do you mean?
I don't know.
So under prepping is you can under prep in different ways. Like, for example, you can the amount of drills will depend on the bone density, right? So if you have an extra soft bone, you will under prep more. You're going to drill less, right? Up to a point of the most radical under prep, which is you use a pilot and then you place your implant. That's a very drastic under prep, right? You only use one drill, the initial drill, and then you place your implant. That could happen depending on the cases. I'm sure Dr. Desmond here has been doing a fixed full arch for a while now. I'm sure that you have faced a lot of cases where you're left off like there's nothing here, very, very soft bone, and you have to under prep drastically like that, right?
Yeah. Sorry, to come off.
So
typically, as you're saying, Dr. Bruno, a lot of times for fixed cases, you can go straight from the precision drill all the way to a 4mm implant, or sometimes a 5mm implant.
Yeah.
And that's why I always said using the precision drill is key to understanding how much do I need to under prep? Do I need to do 3 drills? Because a lot of times the drills in the further part of the kit are not used. Because the BLX is, or the Neodent or the Active, they're so aggressive that they will prep the osteotomy for you. So I think to answer that question in totality would be the best way to under prep is with experience is to use a precision drill, and you get a tactile sensation, and based on that, you'll know what drill you need to go up to. And it's always better to underestimate, meaning that if I think it's hard bone, I'm going to pretend it's medium bone. If I think it's medium bone, I'm going to pretend it's soft bone. You can always go back and re-prep if
Totally.
needed.
Yeah, no, I couldn't agree more. I mean, you can always drill more. If you place your implants too much torque, you can remove the implant, drill more, and place the implant again. But if you go over, you can never come back, right? So it's always better to be conservative on that. And remember, not only you use that pilot to fill the bone, and then you decide, and then like I said, you be safe. You can also use the drills, let's say 1/3 of it, 2/3 of it, right? So you don't have to just not use it completely. You can use just half length or 1/3 of the length if you just want to prep the cortical. So there's different ways for you to under prep according to that case. Remember when we talked about having a hard cortical, the 2C type bone case, right? Hard cortical, very bad medular. Maybe you should go with the drills all the way to the end on the top, maybe just using 1/3 of the drills, but not using the whole length, that one, you would only use your pilot to go whole length because the medular is very soft. You don't want to open the medular more, but you want to open the cortical more. And so this way it would, go full length with the pilot. And then the next drills, you would just go on the cortical, and then you would place your implant. This way you would have relieved the cortical plate, but you would have a tighter medular area. Make
So
sense?
that a good example of that, Dr. Bruno, is in the posterior maxilla, or even sometimes in the posterior mandible, where they have the medular bone above the nerve is completely soft, and the implant is only going to get its stability from that superior cortical
Yep.
bone. So you just want to prep just enough that you're going to get the torque just from the cortical bone, because you know that if you put the implant too deep, it's going to go from 70 torque, 50 torque, and it's going to lose torque completely and just drop.
Yeah, so in that case, you can do this exactly that we talked about before. Like you can just open the top and not prep the medular and place the implant. But if you do have to rely on that cortical plate, remember that we don't want to compress the cortical plate too much because we don't want to have bone dieback there, right? So if you are thinking about using the cortical to hold your implant, you have to be very careful because you should not over compress that. So I would no way go over 45 on that cortical plate. And of course, we understand that if you are in wide, more medular ridges, you can usually compress more if you are, because usually you have more nutrition, more irrigation going around. If you are in very narrow ridges, most corticalized ones, then you have less forgiveness, right? Then you have more chances of having that bone dieback or having some implant failure because you don't have enough nutrition around it. So you cannot overcompress even more. It's even more critical in that situation, right?
What diameter implant is appropriate for lower implants for locator overdenture, assuming adequate bone width?
Well, that's you can do locator overdentures with with a lot of different implants, even like shorter implants. I would say that a very common and on the literature, very like backed up implant would be like a 10mm implant or longer. For that, I would say that if you have an implant that is like a 3.5 by 10 for overdentures, for lower overdentures, or 3.75 would be great. So that you guys know, 3.75 implant is, let's say, the standard. And so that means that it can even be used on single molars. But a 3.5 is an implant that is not, according to FDA, is not good for, is not, let's say, appropriate for molars, according to them. And so when we make these recommendations, we have also that regulatory in our mind. So as a clinician, I could say one thing because I see the papers and I see, but according to FDA, I cannot, recommend something that is narrower than 3.75, let's say, for a molar, right? So depending on where you have those implants, so if you're talking about maybe a 2 implant or a 4 implant overdenture where the implants are closer to the anterior zone, then you could use a narrower implant than that. And so on the BLX line, the 3.5 by 10 would be a great implant for that case. But of course, we see implants being, even mini implants being utilized for locators, right, in the anterior zone. So we have that as well. We have the ridge fit for the Straumann, but it's, of course, is a different line, and you can use those one body, but those are one body, so it's a little different too, right? Because when you have an implant that it's hollow in the middle because it has a connection, then you have thinner walls, and that's why FDA is more, let's say, cautious about letting everybody use it. And when you have a one-piece implant, then you don't have connections, you don't have any like holes inside, and everything is a solid piece, and that's why it is possible for you to use those as well. But so for a 2-part implant that has a connection, on the anterior zone, a 3.5 diameter would be fine for overdentures. And if not, if you are going to do a one piece, you can even use the the ridge fit. That would be like a lot narrower implant, right?
For an Olon 4 or 6, what is the smallest width of an implant with BLX?
So BLX, the smallest, the narrowest diameter is 3.5. And you can use 3.5 rock solid BLXs for fixed full arch. Again, the FDA recommendation is for the molar areas. You should not use 3.5s. You should use 3.75s. If you ask me if I have seen people using 3.5s, yes. For posteriors, yes. Do I see problems happening? No. So statistically, I see zero issues. But again, because of regulatory, because of FDA, we have to say that for the molar area, you should be using 3.75 and up, and not using something that is narrower than that. But for all of the other regions, like on the more anterior to that, you can use a 3.5 without any problem. Okay, fixed full arch is actually even better, and it's less critical because all of the implants are splinted together, right? Everything's splinted together, so everything is working as a group. Let's say one implant is helping the other, right? So dissipating the forces as a structure, not just as one implant. And so we see a lot of cases being done with 3.5s, even on the distals for fixed full arch. And like I said, statistically, we don't have anything that we think is concerning. We don't have, even for, let's say, Dr. Desmond is in Clear Choice. Clear Choice does a lot of fixed full arch per year. We have the statistics from them. We don't have any fractures that we would be thinking about changing anything in terms of the product. So we think it's very safe for you to do. So if you're asking about the narrowest possible one, I would say that one.
And there's a follow-up to that question, and I might butcher this word, so I apologize. Do you consider pterygoid, did I say that right? Implants instead of zygoma?
Yeah, so pterygoid implants are very interesting. Pterygoid implants are, although they are invasive, although they are, going into an area that is very sensitive, it is actually less invasive than zygomatics. But I think that both types of implants should be done by very experienced doctors. Zygomatic, I think you need to have not only a lot more training, but we have zygomatic courses in Straumann and Neodent, and and I'm part of both, in both courses, in both trainings. We take people to learn in different countries, and I really think that for somebody to do a zygo, you should be really versed into more of oral surgery, because you might not have issues, but when you do, they can be big issues. Zygomatics. I've seen zygomatics popping, like the buccal part of the zygo popping out. I've seen different things happening. I've had zygos my own cases with zygos where big fixed full arch case done, very expensive cases where you have individual crown preps for the structure and you have each crown cemented separately. So very expensive cases. Working for 13 years and you think that everything is great, and then on the 13th year, patient had very bad sinusitis. We had pus coming out from the top and from the bottom. Patient lost everything. Then you have to, now what do you do? What if you don't have enough bone here and you didn't have any bone to start with? Now what do you do? So you have to go back to a denture for a little bit because you had to do a sinus lift because there was nothing else for you to place that zygo. And so I am not a big proponent of having any let's say, beginner or even intermediary clinicians doing zygos, I think you have to be very, very experienced and experienced with big surgeries to do zygo, because if anything happens, you're able to handle that. Pterygoids are better than that, but they are still in a very sensitive area of the body. You have important structures there. I think that they provide great stability, and they can make the difference for you not to use zygo, which I think is great. But you do have to be very experienced as well. You do have to learn and shadow with somebody who does that for a while, and to be able to get the feeling and the visualization of everything, because you also don't want to be placing implants in the in that area, right? You don't want to end up with an implant in close to your brain, to the patient's brain, right? So it's also an implant that should be done by experienced people. But I think it's great, and I think I would say it's better to go for pterygoids than to go for zygos if you have the possibility. In a case, I would leave zygos for really the cases where there's nothing else that you can do, and then you have to go to zygo. But if you can even do bilateral sinus lifts, I think that is a better thing for you to do before going to zygos. And I think it's all dependent on how you sell the case. The patients will understand if you explain to them why you're doing this sinus, why it's going to take a little longer than if they just went with zygos, but you are still giving them a plan B in case those don't work in the future, right? And sometimes when you just do zygos in the beginning, then patients might not have another chance in the future.
Going back to the canine implant case, well, oh no, wait, oh no, this is a new question. Going back to the canine implant case, will there be a restorative problem if there is more bone on the palatal as compared to the buccal bone?
So if you have a socket, you usually don't have problems because the alveolus is there, right? You have more problems when you have, let's say, a healed site that healed in a different way, and you have more bone than what you should have, and you didn't take care of that bone before you place that implant. You saw one of my cases, I did a parabolic osteotomy because my bone was very close to the zenith of the gingival margin. That is a case where you would have restorative problems. Inside of a socket is very, let's say, is very good because you already have the emergence profile in the bone and in the gum that you need. And so what you're trying to do is just to preserve that. If you place your implant and maybe that implant was placed more palatally or lingually than what you wanted when you placed it, and maybe to place your temp, you are hitting that wall, and so that could be a problem, right? So if that happens, because even if you use a bone profile, Drew, and you get rid of that, which you can do, but you could end up with an emergence of that crown that is more lingualized or more palatalized than what you would like to. And so although we want to have the 3 millimeters of space between the buccal wall of that implant and the buccal wall of that socket, but don't overdo this, right? Don't bring it to a restorative problem that you have something emerging, like lingually to the alignment of the rest of the teeth in position. So be mindful of that. But other than that, if it's in a good position, if it's lingualized but in a good position, if it's more subcrestal, and if I have more bone just going up, but the implant's in a good position, that does not give you any restorative issues. If you place that abutment at time of surgery, right, like I did, if you are immediately loading. If not, on the canine case, I did put a healing. Why did I put a healing there instead of a cover screw if I was not going to have that healing exposed? It's exactly because of this. I didn't want to have bone overgrowing, and then I might have some issues to be able to, to have to open up the bone. So I have to use a bone profile drill later on after integration to be able to open up the space again so that I would not have restorative problems. So instead, I try to hold the bone dimensions with the healing abutment so that the bone would not ingrow on top of my implant. And so that's the reason, right?
So this looks like it's the last question. How long are you waiting to restore an implant with 35 NCM insertion torque?
So, and by the way, one thing that I didn't talk about is if you are unsure, and if you ask for 35, it's because you're thinking about singles. If you are unsure, if you're doing some of your first cases of immediate loading in whatever zone, if it's anterior zone or not, but one thing that I recommend is if you're unsure, lute that temp with the neighboring teeth without having acid etching on the neighboring teeth, just with adhesive, just to give you an extra, confidence, let's say, during osseointegration. After osseointegration, you would just break those and have the teeth all individually situated. So that is one tip that I forgot to mention during the presentation. If I have an implant placed 35 or more, I was sure of that, good level of stability, like progressively became more and more stable, and this way it stayed. Not like my canine, which I got 35 and then it would fall and then it would get again, and then so it's a little trickier area. If it's that way, then I would not load. If it's something that progressively became better and better, and it ended up 35, then I could just, have my maybe 3 months after I would load that case. It also depends on how much are you waiting for the rest. Let's say if you filled the gap of that socket, how big was that socket? How long would you wait, because of also the biomaterial that you want to integrate? So, maybe something between 3 to 4 months. If it's an anterior socket, 3 to 4 months, I would be fine with that level of torque. And with a Straumann BLX, which has a hydrophilic surface. With the hydrophilic surface, if you're placing in healed sites, and you have that level, like 35, 45 newtons of torque, you could be, loading actually sooner than that, like within 2 months, maybe even a little earlier than that. But because you're placing this in a, and filling the gap, you also have that biomaterial. And so for the biomaterial inside of a socket, for socket preservation, we usually wait for like, 3 to 4 months. And so because it's just a fill, it's not the whole socket, you would be fine within 3 to 4 months for the implant and for that socket and for that graft.
So that's all the questions. So I think we're done. Went a little bit over time, but I'm happy that, we had some good questions come in. I want to thank everyone that attended, everyone that's listening. Thank you for joining us. Thank you for listening, and thank you for all of your questions. And obviously, thank you to Dr. Brown and Dr. Bruno for doing this for you guys. Yeah.
Yeah, I would like to thank all of you. Thank you, the participants, and thank you, Aspen and the Aspen leadership, and Dr. Brown for the opportunity, Melissa for arranging all of this with us, and for moderating. So thank you very much, guys. This is my email here from Straumann. So if you have any further questions, please let me know, and we'll be happy to get back to you. And with that, have a great evening, everyone. We hope to see you guys soon in another great opportunity like this.
Thanks, Dr. Bruno.
Thank you so much.
Thank you, guys. Have a good night.
Bye.